Hurry up, love, this baby is not just going to walk out of me. Hello. My name is Betty, Neopuff, and today is my due date.
Wonderful. Just through these doors and your nurse will be available to you.
What is wrong with my baby?
After running some tests, it appears that he has a condition known as the transposition of the great arteries. Not to worry, Mrs. Neopuff. We have everything under control.
So is the RT for Mr. and Mrs. Neopuff. Could you expand more on what their baby's condition was?
Absolutely. With TGA, the great arteries are reversed in the origins from the heart, with the aorta connected to the right ventricle, and the pulmonary artery connected to the left ventricle, exactly the opposite of the normal heart's anatomy. In this case, the two circulations are separate, rather than being in series with each other like the normal blood flow of the heart. As a result, blood flowing from the right side of the heart goes through the aorta first and out to the body, completely bypassing the lungs where it is supposed to get oxygenated. To further complicate the situation, blood in the lungs goes to the left atrium, left ventricle and back to the lungs again by way of the malpositioned pulmonary artery, going in a continuous circle. The result is that highly oxygenated blood keeps recycling through the lungs, while oxygen-depleted blood recycles through the body, without going through the lungs to reoxygenate.
Wow. That sounds pretty serious.
You think?
How do you fix something like this?
Well, a condition like this ultimately required surgery in order to fix it, but the baby has some time with the help of the shunting of the foramen ovale.
What is that?
A small hole in the atrial septum formed during fetal development, that becomes the mechanism that allows minimal blood mixing to occur in the neonate's heart to keep it alive. This aperture is only open for a couple of days after birth and then it closes. This is why it is imperative to take immediate action upon diagnosis.
So Julie, tell me what is going on.
Yes, doctor, our patient has cyanosis when he cries, has shortness of breath, tachycardia, tachypnea, and I've noticed he has a gallop rhythm.
Okay. Well, what have you done for our patient so far?
I'm giving him supplemental oxygen, which according to the ABG has had no effect on their arterial oxygen level. This was the reason why I first suspected a cardiac defect was present.
Very good. The chest X-ray demonstrated the classic egg on a string appearance that we find in 1/3 of our TGA patients. And the echocardiography showed the specific features of TGA. Since the echocardiography was good enough to give us the definitive diagnosis, cardiac catheterization was not necessary. I want you to maintain our patient's ductal patency with continuous intravenous prostaglandin E infusion.
Yes, doctor. Right on it.
So the doctor mentioned prostaglandin infusion. What exactly will that do?
We use it to promote pulmonary blood flow, increase left atrial pressure, and promote left-to-right intercirculatory mixing at the atrial level. It is in cases like these that we want to keep that shunt open so that the blood that is getting oxygenated can mix into the right side of the heart and out to the body until we can surgically correct it by way of the arterial switch operation. Prostaglandin E will do just that, and buy us some time.
Now what if this prostaglandin does not work? What are the next steps?
Intubation and ventilation are usually required because of hypoxemia, acidosis, and prostaglandin-induced apnea episodes. Oxygen is given judiciously to help maintain the appropriate balance between pulmonary and systemic blood flow. Cardiac catheterization can also be used to perform a preoperative procedure known as balloon atrial septostomy, where a balloon tip catheter is guided through the groin to the left atrium and is inflated and pulled back into the right atrium, tearing the atrial septum. The success of this procedure is measured by the observable increase in oxygenation levels. Now that the desired oxygenation can be achieved, the focus can be directed toward the best surgical method.
Okay, Julie, please help prep the patient for surgery while I discuss it with the parents.
Doctor, please tell me my baby is going to be okay.
He will be just fine, Mrs. Neopuff. There are a couple surgery options for TGA, but I am going to be performing the arterial switch operation because that is what I use the most, and I have had much success with it.
Thank you so much, Doctor. Now hurry up and go fix him.
Alrighty then, Mrs. Neopuff.
Can you tell us about this arterial switch operation?
Sure thing. This action gives the patient both physiological and anatomical repair. It is usually done during the first month of life. The pulmonary artery and the aorta are moved to their normal positions. The pulmonary artery is connected to the right ventricle, and the aorta is connected to the left ventricle. The coronary arteries are also reattached to the aorta. Being that ventricle septal defects, atrial septal defects and patent ductus arteriosus are normally associated with TGA, it is appropriate to mention that the enlarged ventricle and atrial defects are also resolved during this procedure, although swollen holes are sometimes left to close on their own.
He mentioned there are a couple surgeries. What could the other be?
Whereas the arterial switch operation reverses the vessels themselves, there is also an atrial switch operation that mimics the Rashkind procedure, but uses a permanent fixture, known as a baffle between the heart's two upper chambers. This routes the deoxygenated blood coming from the superior and inferior vena cavas directly to the mitral valve, left ventricle and pulmonary artery, where then the oxygenated blood coming from the lungs is routed directly back to the tricuspid valve, right ventricle and aorta. This puts the burden on the right side of the heart to pump blood to the body instead of the lungs, which it would normally do. This creates future complications such as irregular heartbeats, baffle obstructions or leaks, and heart failure due to problems with right ventricle function. Given that the statistics show a survival rate of 78%, versus the arterial switch operation having a survival rate of 97%, the latter is preferential. However, morphological conditions prevail in the final determination as to which procedure is utilized.
Great news, Mr. and Mrs. Neopuff. Your baby's surgery went wonderfully. Don't be alarmed when you see him on a ventilator. It is just temporary until he can stabilize, maintain his oxygenation and pulmonary function on his own.
Oh, Dr. Stack, thank you so much. But what caused my baby to get this?
The heart develops during the first 8 weeks of fetal growth. It is believed that the malformation occurs sometime in the middle of this development. The causes are not known, but have been hypothesized to be prevalent in women with maternal type 1 diabetes mellitus, which you have, and possibly with the ingestion of certain drugs, such as benzodiazepines. There are other opinions citing rubella, measles that appear as a rash on the skin, and other genetic abnormalities such as Down syndrome as a possible correlation. However, since there is no identifiable consistency with any of these, researchers have officially deemed the exact cause of TGA inconclusive.
Will our baby grow up to be a normal, healthy child?
Well, in spite of the survival success rate, your child may require lifelong monitoring by a medical professional.
What a miraculous story. Who knew that there are so many different kinds of cardiac defects?
Oh yes. Transposition of the great arteries is a serious malformation of the heart with grave consequences if left untreated. Recognition and diagnosis of the disease can often be challenging and sometimes undetectable with the combination of additional septal defects frequently seen, with the help of the respiratory therapist. That would be me. And their expertise in maintaining oxygenation and pulmonary function along with surgical measures such as the arterial switch operation, TGA can be successfully managed. Respiratory therapists have an integral role in the initial diagnosis by helping rule out pulmonary disease and isolating cardiac malfunctions by using techniques such as the hyperoxia test with the help of analyzing arterial blood gases. Another responsibility is maintaining the patient's oxygenation and pulmonary function at acceptable levels, which could be accomplished by giving supplemental oxygen or by going as far as performing intubation and ventilation. These steps are essential to sustaining the viability of the baby. Aspiring respiratory therapists should be familiar with TGA as it is within their scope of practice to treat such a patient.